was delighted to get Professor Yellen's invitation to speak at this prestigious meeting. And you can see his title challenges me to concentrate on novel developments in this old clinical problem, which indeed will be my focus after introducing the background in the first slides. So diuretic resistance is recognized clinically as continued congestion or edema despite a full dose of a loop diuretic, such as furosemide 80 milligrams twice daily. This slide shows the response of normal subjects to furosemide over 3 days at a high level of salt intake in the top slide and a low level of salt intake in the bottom slide. And the data is shown as excretion in millimoles per 6 hours of the day. You can see that during the high salt intake we are in balance because the 6-hourly sodium excretion was close to the 6-hourly sodium intake of 70 millimoles. Shown in gold is the large increase in sodium excretion in the 6 hours after 40 milligrams of intravenous furosemide. But what caught our attention was the remarkable reduction in sodium excretion in the post-diuretic phase, which offset all the sodium lost as the response to the diuretic. On the second day it was given orally, the third day intravenously, and it was the same pattern on each day of salt loss, followed by renal salt retention, so that over 3 days we lost no net salt and no body weight on this high level of salt intake. In contrast, on a low salt intake in the lower panel, equivalent to 5 millimoles per 6 hours, the salt excretion with the diuretic is somewhat enfeebled, but there was no way the kidney could restore salt balance because no salt, virtually no salt, was present in the diet, and we all lost salt over the 3 days and body weight. And it reminds us of 2 things. First of all, the response to a loop diuretic is not just the pharmacological response to the drug itself, but also entails a response of the kidney following the diuretic, which can completely extinguish the salt lost during the diuretic phase. And secondly, even with loop diuretics in patients without a salt-retaining kidney here, we have to consider the level of sodium intake if we want to ensure salt loss. And in practice, a level of sodium of 2 to 3 grams per day is usually a good target for patients at least with moderate diuretic resistance. So this clearly looked like the sodium retention after the diuretic was a compensation to salt lost. So to test this, we, on another occasion, came into balance on a 100 millimole a day salt intake. And on one occasion had 100 millimoles extra of salt. And you'll see in green that over the next 2 days we excreted 95% of that salt load. On a second occasion, randomized, we had a single 1 milligram of bumetanide intravenously, but were never salt depleted because we had an ongoing sodium chloride infusion equivalent to the salt and water lost in the urine. And when the diuretic was eliminated, we were then challenged again with 100 millimoles of sodium, and you'll see that now the kidney retained all of that sodium over the next 2 days. This shows that post-diuretic salt retention is not a compensation to salt lost, but a pharmacological response to the diuretic. And as we looked in animals in the distal tubule, you can see remarkable hypertrophy of the early distal tubule in rats given furosemide for 5 days, actually, in the bottom panel, compared to control rats in the top panel, suggesting then that upregulation of transporters in the early distal tubule may be an important component of diuretic resistance. In another study, we looked at the collecting ducts in a similar protocol. And although there was no change in the A cells, the acid-secreting intercalated cells, the B or base-secreting cells were enhanced in volume by about 30%. And we now know that this is important because this is the site in the B cells at the bottom of the action of pendrin, which is a chloride bicarbonate exchanger, and the sodium-dependent chloride bicarbonate exchanger, which is closely linked to it. And these are sites of diuretic action, thiazide diuretic action. Indeed, remarkably, up to half of the natriuretic effect of a thiazide is due to blockade of sodium reabsorption in the collecting ducts. And therefore, this upregulation of the B cells could be an important component of diuretic resistance and a rationale for co-therapy with a thiazide. This shows a clinical scenario of a patient with severe diuretic resistance due to the nephrotic syndrome. A patient was given 240 milligrams of furosemide daily and 40 milligrams of KCl, but remained massively edematous, and as you will see, had a dangerously low serum potassium at the bottom. Giving the furosemide twice a day and doubling the potassium intake got the serum potassium up to just barely the bottom limit of the normal range and had little effect on body weight. Adding hydrochlorothiazide, 25 milligrams, which you may think was a feeble diuretic compared to 120 twice a day of furosemide, led to a progressive loss of about 8 kilos of body weight, but as you'll see, a progressive fall in serum potassium to dangerously low levels again. And the serum potassium could be restored by blocking mineralocorticosteroid receptors with eplerenone. So this indeed shows that in diuretic resistance, blockade downstream from the site of action of loop diuretics with a thiazide and perhaps a mineralocorticosteroid receptor blocker can have beneficial effects. More generally, Jeffrey Testani showed in this study of patients with diuretic-resistant heart failure, using the clearance of lithium to mark proximal reabsorption and the excretion of diuretics in the urine to mark the pharmacokinetic adaptations. You can see that he concluded that about 2/3 or 3/4 of the diuretic resistance was due to inappropriate salt retention downstream from the site of the loop diuretic. If we go through this then, proximal reabsorption can be inhibited by drugs such as hydralazine, as we'll see, and SGLT2 inhibitors, we'll discuss those two in particular, thereby increasing the amount of salt delivered to the target of loop diuretics. There may be a case for switching furosemide to a more reproducible diuretic such as torsamide, or a more prolonged diuretic such as torsamide extended release. I'll show you that. The last slide showed that addition of a thiazide and an MRA can have beneficial effects. And tolvaptan may be a consideration, as we'll see, in segmental nephron blockade. So let's think of hydralazine now. Hydralazine is interesting to us because it has no known direct epithelial transport effects. And so it can be used as a probe for purely hemodynamic approaches to diuretic resistance. This shows the response of a patient with heart failure and preserved ejection fraction with severe diuretic resistance in the ICU that we studied recently. You can see in green the fraction excretion of sodium was almost 0, and the daily urine volume in red was about 400 mils, and the patient was in severe congestion. Increasing diuretic administration up to 20 milligrams of furosemide intravenously per hour and 500 milligrams of chlorothiazide twice daily increased fractional excretion of sodium only to 1.8% and daily urine volume to about 1.5 litres. Now, with the distal nephron blocked with these 2 diuretics given round the clock, a modest dose of hydralazine, 10 milligrams 3 times daily, doubled the fractional excretion of sodium and the urine output and allowed the patient to be discharged from the ICU. So how might this be occurring? And we considered 2 particular pathways. Firstly, hydralazine strongly vasodilates the afferent arteriole and increases the renal blood flow and therefore the delivery of diuretics to the kidney. But we doubted that this was the primary mechanism of action because the loop diuretic and thiazide were being given intravenously round the clock. Hydralazine also powerfully reduces the filtration fraction, which sets the level of oncotic pressure in the peritubular capillaries to take up the fluid and sodium reabsorbed by the proximal nephron. Reducing this with hydralazine, therefore, reduces proximal reabsorption and creates a proximal diuretic action by a hemodynamic mechanism. And we favour this as the more likely explanation for the result shown in the last slide. So now, can extending the duration of loop diuretics improve their efficacy? And you could see in the very first slide how the very short action of loop diuretics leaves the majority of the day open for the kidney to restore the salt lost. And here we approach this by a combined study with a colleague who is developing an extended release form of Torsamide ER here. And in the first slide you can see the result of that first study I showed you. When furosemide was given during a high salt diet, there was no net sodium loss. 20 milligrams of torsamide also led to no significant sodium loss, but 20 milligrams of torsamide ER led to a much more consistent and about double salt loss compared to the torsamide immediate response. This slide shows some of the mechanisms. In the first panel is the plasma or urine concentration of torsamide when given as immediate release IR in red or extended release in green. And you can see the time to maximal concentration is increased about 3.5-fold. In the second panel, you can see that this leads to a more gradual, prolonged and sustained natriuresis that covers a good deal of the post-diuretic phase here and therefore allows more salt loss than you could get with the immediate release formulation. And indeed, as shown here, the sodium excretion was doubled with the ER. In the last panel was a novel finding, and it relates the sodium excreted to the delivery of torsamide to the urine, which is effectively the delivery to the site of action in the tubule. And you will see in red a marked hysteresis so that the delivery increases rapidly, sodium excretion increases rapidly, and then falls, but not back along the same pathway, but in a hysteretic manner, such that if you look at the 2 micrograms per minute torsamide getting to the urine, it causes a maximal natriuresis on the way up and virtually no natriuresis on the way down, showing within dose tolerance to the loop diuretic, which hadn't been noted previously. And another mechanism whereby the extended release drug was more efficient and more effective was that the subject spent longer on the more efficient ascending phase of this hysteresis curve, so that the overall efficiency, which is the amount of salt excreted per torsamide getting to the urine in the last column, was double with the extended release. So let's consider sodium glucose link transport 2 inhibitors. And as you know, these block the reabsorption of sodium coupled to glucose in the proximal tubule. But this is normally a modest pathway, accounting for 5 or not more than 10% of sodium reabsorption in the proximal nephron. However, direct micropuncture measurements show that in fact, blockade of SGLT2 blocks about 1/3 of proximal reabsorption. And that's explained by the finding that SGLT2 is structurally and functionally linked by a chaperone protein called MAP17 or PDCK1 protein to other proximal transporters, notably sodium hydrogen exchanger 3, which is responsible for the reabsorption of about 2/3 of proximal sodium. The net effect of blocking SGLT2 in the bottom, then, is a much bigger inhibition of proximal reabsorption than we might have anticipated, and therefore a much bigger delivery of sodium and chloride out of the proximal tubule into the distal nephron. And this led us to the hypothesis, then, that SGLT2s might have a synergistic interaction with drugs such as loop diuretics that work downstream. And this is shown in the first panel here in green, where SGLT2 inhibitors increase the amount of salt delivered to the target for loop diuretics. And in red, loop diuretics induce the release of renin and the generation of angiotensin that is responsible for increasing the expression of SGLT2 and NHE3 in the proximal nephron, and thereby increasing the target for SGLT2 inhibitors. Setting the scene for our hypothesis, then, for a mutual two-way synergy between these two groups of drugs, which we tested in a study of normal human subjects. And here's their response on a fixed salt intake. In green is the increase in salt excretion with a single dose of bumetanide, about 115 millimoles. When other subjects were given this dose of bumetanide after a week of dapagliflozin, in red, you'll see that the increased response of sodium there was an increased natriuresis with bumetanide of about 30%. On the right in blue is the response to dapagliflozin. When given alone on day 1, it has a relatively modest effect, increasing sodium excretion less than 40 millimoles. Remarkably, when given after a week of bumetanide, which you might imagine had caused volume depletion and might further enfeeble the response to dapagliflozin, on the contrary, in light blue, you'll see a 2- or 3-fold further increase in natriuresis, so that now the dapagliflozin in light blue becomes equivalent to the loop diuretic in green. This indeed shows then two-way adaptive synergy between SGLT2 inhibitors and loop diuretics that might prove beneficial in diuretic-resistant patients. And lastly, I'd like to consider sequential nephron blockade. So if it's true, as I've suggested, that most of diuretic resistance is due to enhanced reabsorption of sodium at other nephron segments, it would be logical to try and block many of these segments simultaneously. Equally important, the adaptive increase in sodium reabsorption at these sites sets up the electrochemical forces for enhanced secretion of potassium, with potassium loss and hypokalemia being prominent adverse effects of prolonged loop diuretic administration. So here, the investigators studied 17 patients with acute diuretic-resistant heart failure, given a combination each day of 240 milligrams of furosemide, 80 milligrams of spironolactone, 8 milligrams of metolazone, a thiazide, 500 milligrams of acetazolamide, a proximal diuretic, and 20 milligrams of tolvaptan, an aquaretic that blocks the vasopressin V2 receptor. And you can see in the table that they lost an average of 7 kilograms over 4 days, a pleasing clinical response. And remarkably, there was no significant change in blood pressure, serum sodium, potassium, or bicarbonate, or even glomerular filtration rate. And this strategy then of sequential nephron blockade was really a fascinating demonstration here of the potential of this therapy, which is being investigated in a more systematic manner at a number of sites. So then, to summarize in a final slide, in patients with decompensated heart failure, there's activation of neurohumoral mechanisms that can be beneficially blocked with drugs such as ACEs or ARBs. Additionally, hydralazine may induce a favorable hemodynamic effect in the kidney to impair proximal reabsorption and increase delivery of salt to the diuretic-sensitive segments, and also increase delivery of diuretics to the kidney. In patients taking regular loop diuretics, we might consider adding an SGLT2 inhibitor to enhance proximal effects here, substituting furosemide with torsamide, which is a more predictable diuretic with a better pharmacokinetic profile, or if it becomes available, torsamide extended release, or blocking downstream nephron segments such as NCC with a thiazide, epithelial sodium channel with a miloride, or the mineralocorticosteroid receptor with a drug like spironolactone. And last, but importantly, considering salt intake, because an inappropriately high salt intake prevents salt loss with a loop diuretic, even in normal subjects. Thank you very much.